Welcome to VJOncology Podcasts, where we deliver clinically relevant insights from the latest advances in oncology research. In today's episode, we're bringing you highlights from the San Antonio Breast Cancer Symposium, focusing on new data that may impact treatment strategies across both early and metastatic breast cancer, from updated survival outcomes with HER2-targeted therapies to refinements in adjuvant endocrine therapy and the emerging role of AI in identifying high-risk patients. This episode captures some of the most important clinical takeaways from this year's meeting. We begin with updates from the HER2CLIMB-05 trial, evaluating tucatinib in patients with HER2-positive metastatic breast cancer. In this segment, Erica Hamilton discusses how the addition of tucatinib improves progression-free survival, reinforcing its role as an important component of HER2-targeted therapies, including in patients with high-risk disease features.
Presented HER2CLIMB-05 today. This was a registrational trial looking at the benefit of adding tucatinib to HP maintenance in the first-line setting for HER2-positive metastatic breast cancer. Really, the goal is to prolong progression-free survival and also prolong time off of chemotherapy. This trial enrolled patients that were both HR-positive as well as HR-negative. Over 600 patients were enrolled, and the primary endpoint of progression-free survival by local assessment was met with an 8.6-month improvement in progression-free survival. We did break this data down into the HR-negative and HR-positive subsets. Again, the HR-positive subset of patients were allowed to receive endocrine therapy. We only had about 45% of those patients that did receive endocrine therapy. The benefit was 6.9 months, and this was statistically significant. In the subgroup of patients that had HR-negative disease, this was also statistically significant with a magnitude of benefit of over 12 months. In terms of tolerability, there weren't any big surprises. We anticipate seeing LFT abnormalities as well as diarrhea with the addition of tucatinib to regimen. We did see about 13% of patients discontinuing tucatinib, and the majority of those patients discontinued did so due to AST/ALT elevations. That was 7.7%. Diarrhea was actually a really infrequent reason to discontinue therapy, 1.5% with tucatinib and 0.9% of placebo on the HP arm, telling us really that HP was driving a lot of the diarrhea. So in summary, HER2CLIMB-05 was a positive study. It showed that adding tucatinib for both HR-positive as well as HR-negative first-line metastatic HER2-positive patients in the first line not only prolonged progression-free survival, but also prolonged time off cytotoxic chemotherapy for these patients.
Next, we turn to an exploratory analysis from the ALTO trial, focusing on adjuvant endocrine strategies in patients with hormone receptor-positive, HER2-positive early breast cancer, presented by Matteo Lambertini. This analysis explores outcomes with aromatase inhibitors versus tamoxifen, offering further insights into how endocrine therapy choice may influence long-term outcomes in this biologically distinct subgroup.
At the 2025 San Antonio Breast Cancer Symposium, we presented an exploratory analysis of the ALTO trial, looking at adjuvant endocrine therapy in patients with hormone receptor-positive, HER2-positive disease. The ALTO trial was a large study that included more than 8,000 patients that were randomized to 4 anti-HER2 treatment arms: trastuzumab, lapatinib, their sequence or their combination. In this specific analysis, we included 2,651 patients out of the 8,300 that were included in the ALTO trial. So we excluded those who received lapatinib alone, with hormone receptor-negative disease, with hormone receptor-positive disease that did not receive adjuvant endocrine therapy or receive ovarian function suppression alone as adjuvant endocrine therapy, and also those patients that switched from one endocrine therapy to the other during the follow-up. So by including these 2,651 patients, we looked into the comparison between AI aromatase inhibitors and tamoxifen. At a 10-year follow-up in this large cohort, we observed that patients who receive aromatase inhibitor experience significantly improved disease-free survival as compared to those who received SERM, tamoxifen alone. There was a 3.6% absolute difference in disease-free survival with an adjusted hazard ratio of 0.65. So apparently, the benefit of an AI over tamoxifen is quite consistent, and this was observed regardless of patient tumor or treatment characteristics, meaning that also, for example, premenopausal women, there is still benefit of AI together with ovarian function suppression as compared to tamoxifen, as probably the best endocrine therapy that we can offer also to patients with hormone receptor positive, HER2 positive disease. Then we also observe significant improvement for the DFS, for the AI group for time to distal recurrence, 2.6% absolute difference, adjusted as a ratio again 0.65. However, there was no improvement in overall survival. So our final take on these results, with all the limitation of being an exploratory analysis, but still of a large phase 3 trial with centrally tested hormone receptor status and HER2 status, I think these results are suggesting that probably the preferred endocrine therapy also in patients with HER2 positive disease should be considered aromatase inhibitor based therapy. So together with OFS, if we talk about premenopausal women, which is something that was not very clear. We know AI is superior to tamoxifen in general in patients with hormone receptor positive disease, and particularly in those with HER2 negative disease. Here, these data are adding on the top of this evidence also the efficacy of AI versus tamoxifen in the specific and special cohort of patients with hormone receptor positive, HER2 positive disease.
Artificial intelligence continues to gain traction in breast cancer research, and SABCS 2025 showcased new data from TAILORx examining its role in lobular breast cancer. Roberto Salgado discusses how an AI-based approach was able to identify high-risk lobular breast cancer patients, potentially addressing an unmet need in risk stratification for a subtype that can be challenging to assess using traditional tools.
So one of the interesting things about the community where we reside, the scientific community, is that the TAILORx study, when it was first published many years ago, it didn't include histology. So we had no clue about these different histological phenotypes, whether they behave differently when they have the same genomic risk score. Now, what does this mean? We know that breast cancer is a family of diseases, but the two most important families within that big family are the ductal and the lobular phenotype. Okay. So what we did with the TILS working group, and this was a study that was coordinated and led by Joe Sparano, the PI of TAILORx, we have analyzed the 10,000 slides from all those patients to identify ductal versus lobular histology. And we did find that histology, as defined by the pathologist, is a very important prognostic variable. That means that if you are low genomic risk and you are ductal or lobular, if you have a ductal phenotype or a lobular phenotype, that those who have a lobular phenotype have a very bad outcome. They have at 15 years follow-up up to 5% lower overall survival compared to the ductal. And this is clinically important. Why? Because those patients today get the advice, because you are low genomic risk, we will not give you chemotherapy. We have shown that those patients with lobular phenotype, that they may actually benefit with more treatment because they are low genomic risk, but maybe clinically high risk. In addition to that, to make this diagnosis more precise, we have to combine the pathologist, just like in Affinity, with an AI assay that measures a specific genomic alteration, typically for lobular. And what have we shown is that in the very large majority of cases, pathologists are quite good at making diagnosis of lobular, but there were discordances, meaning it was not perfect. And AI could help us to reduce more this uncertainty of the histological diagnosis. So the combination of the pathologist with the AI was actually a very important prognostic variable and reassuring the pathologist that what they do already is qualitatively. And in addition to that, and that's the second element of AI within the TAILORx, a bit similar like Affinity, we did find that patients who had low genomic risk, that had this different histology, that if you add a metric of the immune system that we co-developed with Case 45, that we could even then identify more patients who were clinically high risk of recurrence. So combining histology by the pathologist plus AI, plus a metric of the immune system with AI, we were able to identify patients who currently today get the advice not to get chemotherapy, but that we believe, based on this evidence, thanks to AI, that those patients could benefit from more extensive treatment because they may be clinically high risk.
Finally, we highlight results from the lidERA trial presented by Aditya Bhadia, evaluating the oral selective estrogen receptor degrader giredestrant in ER-positive, HER2-negative early breast cancer. The discussion centers on improvements in invasive disease-free survival and what these data may mean for the evolving endocrine treatment landscape, particularly as next-generation SERDs move closer to routine clinical use.
At San Antonio Breast Cancer Symposium 2025, we're presenting the results of the lidERA study, which looked at giredestrant, an oral selective estrogen receptor degrader, was a standard of care endocrine therapy for patients with stage 1 to 3 ER-positive, HER2-negative breast cancer in the adjuvant setting. So in terms of the lidERA study, this was a global phase 3 clinical trial which looked at giredestrant, an oral SERD, again an ER degrader, was a standard of care endocrine therapy, which could be aromatase inhibitor or tamoxifen for patients with stage 1 to 3 ER-positive breast cancer. As a reminder, majority of breast cancer are diagnosed as ER-positive disease, about 70%, and majority are treated in the adjuvant setting. So in this setting, we evaluated giredestrant was a standard of care endocrine therapy. The primary endpoint was invasive disease-free survival. About 4,000 patients were randomized 1-to-1 to giredestrant versus aromatase inhibitor or tamoxifen. 84% of patients in the trial received aromatase inhibitor and 16% tamoxifen. In terms of study result, the study met its primary endpoint. There was a statistically significant and clinically meaningful improvement in invasive disease-free survival with giredestrant was a standard of care endocrine therapy. This corresponded to a hazard ratio of 0.70, so a 30% reduction in the risk of recurrence or death with giredestrant as compared to standard of care endocrine therapy. There was also improvement in distant recurrence-free survival, hazard ratio 0.69, so 31% reduction in the risk of metastatic disease with the use of giredestrant was a standard of care endocrine therapy. And finally, there was a trend towards improvement in overall survival. In terms of the safety profile, overall, the frequency of AEs were similar between giredestrant and standard of care endocrine therapy, but discontinuation was lower in the giredestrant arm as compared to standard of care endocrine therapy. Side effects that were higher with giredestrant included bradycardia, majority grade 1, which means that they were asymptomatic, did not need treatment discontinuation or any management. This was just something that was picked up on routine monitoring. So overall, lidERA met its primary endpoint. Since the approval of aromatase inhibitors in early 2000s, after 25 years, this is the first study that has shown positive results with the new endocrine agent for patients with early stage ER-positive breast cancer.
Thank you to all of our speakers for sharing their insights from the San Antonio Breast Cancer Symposium. Across this episode, we've explored advances in HER2-targeted therapy, adjuvant endocrine treatment optimization, the growing role of AI in breast cancer's risk stratification, and emerging data supporting next-generation endocrine agents in early disease. Thank you for joining us on this episode of VJOncology Podcasts. For more expert commentary and Congress highlights, visit VJOncology.com. And don't forget to subscribe to stay up to date with the latest developments in oncology research and clinical practice.